Hello everyone, I'm Alfonso Jurado from La Paz University Hospital. It's a pleasure for us to be another Wednesday here in the MedStream program, and beside me is Ana, our nurse scrapping, Chus is outside, and also Dr. Borja Rivero, one of our fellows, is helping us in the control room. We are doing this first case that is a multivessel patient, and Borja is going to explain you the case. Borja.
Good morning, everyone. Today's first case is a 51-year-old man with a medical history of hypertension, poorly controlled diabetes, dyslipidemia, and former smoker. He suffered an acute cerebrovascular accident in April 2023, and he was admitted due to exceptional angina. An echocardiogram showed a normal left ventricular ejection fraction, but revealed inferior akinesia. Analysis results indicate a low-density lipoprotein level of 200 and a blood glucose level of 500. The treatment plan includes dual antiplatelet therapy, rosuvastatin, and ezetimibe. A diagnostic coronary angiography was performed, revealed significant stenosis in all 4 coronary vessels with distal disease, including a chronic occlusion of the circumflex artery. Therefore, a decision was made to proceed with percutaneous coronary revascularization. The patient was enrolled in the Multivessel talent study with randomized patients to receive either ultrasyn supraphyleal cruise or synergy stent guide intracoronary imaging for multivessel disease based on angiography derived QRF. Today, the plan is to perform a multivessel percutaneous coronary revascularization guided by intracoronary imaging.
Jordan, Borja?
Okay.
Okay, so I'm going to explain you, give me 1 second only to retrieve this balloon. I'm going to explain you the setup and the things we have done till now. Okay, you have the balloon. So these are the angios of today. This is a quite difficult to decide case, as Borja explained you, because it's a very young patient with risk factors and this multivessel disease. The right coronary artery is going to be deferred to other procedure, and we are going to treat the left coronary artery. As you see, there is a chronic total occlusion or subocclusion of the circ, that it seems to be a small vessel. We don't know, because probably it has a codominance between the right and the circ. And we are focusing today in the intermedius branch and also the LAD. This is the caudal projection in which you can see 2 lesions, 2 focal lesions in the intermedius branch at the ostium, and more severe in the intermediate portion. And also, this is the LAD that is quite developed and diffusely diseased. He has a clear severe lesion at the mid, focal lesion at the mid segment, and also moderate, angiographically moderate lesions at the proximal part and also the distal part. Interestingly, we have crossed a wire to the intermedius branch and to the LAD, and the patient developed some vasospasm with ST elevation, anterior ST elevation, because of the vasospasm of the LAD. And after administering nitroglycerin, we have performed an IVUS. Borja, can you show the IVUS, please? Borja, can you show the IVUS?
Okay.
The first one.
First one. 1 second.
That'll play. Play. So you are seeing the pullback from the distal LAD. This is the healthy segment. You're going to see right now the focal lesion. Probably this is a bridge. You can see the eyebrow sign, and here is the severe lesion. You can see the plaque there, and the distal reference diameter is 2.5. This is the lesion. As you are seeing, some calcification, not severe, and the proximal part, the proximal landing zone probably is 3 millimeters in diameter. It's quite healthy. And the proximal part that was indeed without nitroglycerin, you are going to see a diffuse disease with a minimum lumen area of 4.5 more or less, but taking into account the vasospasm of the patient. You are seeing here the diffuse disease, some calcification, probably is a mixed plaque, some branches arising from the bottom of the image. And we are reaching the proximal LAD. And now, after completing the pullback, Borja is going to show you the B4 bookmark, in which he has measured the luminal area. This is the bifurcation, the carina, and the left main that is more healthy than the LAD. Okay, stop and show the B4, B4, proximal. Vale. And this is the measurement of the area of the proximal ostial LAD, 4.5 more or less. It depends on the frame, but with vasospasm. The vessel has increased a lot after nitroglycerin. So we have decided to treat the critical lesion at the mid part and be conservative at the proximal part, because if we treat it, that it could be done, we probably need to treat also the left main, jailing the circ and the intermedius branch. And probably it is not needed today. So the setup is, I forgot to explain you, radial approach 6 French with an XB 3.5 guiding catheter and 2 cyan blue wires in the LAD and also in the intermedius branch. This patient has been included in the multivessel talent trial that Borja had explained you, comparing the synergy against the supraflex screw, this ultra thin stent that we are using more and more in our country. And all the patients should be treated with a double antiplatelet treatment with novel drugs, with prasugrel and aspirin. And also all the implantation should be optimized with imaging. We are always thinking which is the best stent. All of them are quite good. All the platforms we use now are quite good. And some colleagues think that probably the ultra thin platforms are the best one in every case, and probably they have more flexibility, more deliverability, but probably a little bit less radial strength and a problem of visibility probably, but they are quite good in almost every scenario. And also the synergy stent that they have a lot of data and we use it a lot with very good results. So the interesting point of this trial is that we need to optimize everything with imaging, and it's based on physiology, because we are doing this non-invasive physiology before ¿me dais a live, porfa? Borja, live, arriba. Ahí. Okay. I'm going to advance a little bit. There, and pull back. So this is a bridge. You can see this image, probably is a bridge. And this is the stent. We are going to see some under expansion, but I think that the result is going to be better than before. Probably this was the area of under expansion near here. It's quite better than before. This is the worst part. Okay, but I think the area is quite good. We can measure afterwards the MSA. Done. It's near 4.5, 5, it depends. I think that taking into account the safety and the result is okay, because we are not going to post-dilate with a bigger balloon, and this is a reasonable result near 5 millimeters square. So we are moving to the intermedius branch. The patient is okay without ST elevation that he developed before with the vasospasm of the artery. Okay, this is the pullback from the intermedius branch. This is not a very big vessel. This is the focal lesion probably there. is hugging the catheter, probably is quite severe there. Healthy here, and it's important to see the ostium. Okay, this is the ostium, and we are in the left main. Okay, stop. So Borja, we need to analyze the same, similar than the lady, the distal reference diameter, because the mid lesion is for sure severe.
Okay.
And after that, we have to measure the severity, the area of the ostial intermedius branch. So this is a small vessel, go proximal to the right, or proximal. Probably when you see the structure, okay,
Okay.
probably there you can measure a line to see the reference diameter. Okay, 2.25, 2.5, okay.
Okay.
And now the proximal one, this is the lesion, okay. Proximal, 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 okay, there.
Okay.
Some calcification, but not too heavy. 2 point something. I think that with a 2.25 or a 2.5, this is the decision. Probably this is more proximal, that we are not going to land there. Okay, and now we are going to evaluate the proximal, the ostium. The ostium. Okay, there, an area, please. We have administered nitroglycerin, but after crossing the wire, we have again a vasospasm. It's similar than the LAD. We have a clear disease there, but a 4 point something probably is less than 4.6. It's a more disease vessel right just distal to this frame, but 4 point something I think is more elegant, smart, is more beneficial for the patient to treat only the focal lesion at the mid part, and then leave the ostial part, just not treating the left main, because probably there is no need now. We're going to use the initial balloon of 2.5 by 12 that we used before for the LAD. We're going to be cautious with the dilatation, because the lumen is near 2.5. I think the best landing zone distally is a little bit farther the critical lesion. I'm going to use a smaller stent at 2.25, because the luminal area was between 2.2 and 2.5, and then analyze with IVUS if we need to post-dilate the proximal part. Okay, let's go with the stent. Okay. Quite good expansion. Baja. In angio. We're going to administer nitroglycerin again and check with IVUS. We're going to dilate. The stent is okay, so I think we have not. We don't need to post dilate it, and we are going to dilate the proximal part. Is not the ostium. My idea is to dilate this proximal part, being sure to not enter in the left main, and then try with a drug-eluting balloon, because we have only a couple of millimeters of a healthy or less diseased zone near the ostium. So if the result is okay with a drug-eluting, okay, balloon probably is a good idea. Look, there is some dissection at the proximal part, but it's a A or B dissection without impairment of the flow. The ostium of the lady is the same. So I think we can do a final IVUS in the intermediate branch and finish the case for today. We have used 180 IVUS. 180 cc's of contrast. And I think this is enough for today. We are going to follow the patient in the outpatient's clinic and if he has some symptoms, we can go for treatment of the right, and also for this chronic total occlusion of the circ. Okay, this is the distal vessel. Some disease here, very distal. The stent is quite good. I think that we haven't dilated with the drug-eluting balloon here, probably in the proximal part of the stent. The stent is quite good. Let's see, probably we can see the dissections at the proximal part at some point. Probably there. Okay, okay, very good result. So this is the final angio of the intermedius branch. The stent is quite good. We have the dissection at the proximal part, but with the drug-eluting balloon. It's a very good result in my opinion. This moderate lesion at the ostium of the LAD that we have decided to be conservative today. And the final, this is the caudal view, and the final result of the LAD, that is, I will show you. I know where is the cine, but we have checked with the IVUS and it's quite good. Okay, let's do another one in the coronary view, because I don't know if we have done it. Very slowly. Okay, I think we can retrieve this wire here, this one here. Dame más nitro, por favor. More nitroglycerin. If we have to do another one, probably it's better to administer more. Blood pressure is quite good. Okay, contraste. Okay, let's wait some seconds. You are seeing with this diffuse disease that the best portions of the vessels are the portions we have treated. Okay, Rolada, cine. Yeah, very good. Okay, so I think we have finished the case. I'm going to retrieve everything and see you in the next case at 2 p.m. Madrid time. See you.